Chapter 1, Foundations of Psychiatric Nursing. So, psychiatric nursing is composed of mental health and mental illness. Both are culturally defined. So, some cultures are more liberal than others. Therefore, this definition may vary according to culture. So, mental illness is defined as a maladaptive, so remember that, maladaptive response to stressors. Okay? From internal or external environment, evidenced by thoughts, feelings, behaviors that are incongruent with local and cultural norms and interfere with individual social, occupational, and or physical functioning. Mental health. Mental health is a successful adaptation to stressors from internal and external environment, evidenced by thoughts, feelings, and behaviors that are age appropriate and congruent with local and cultural norms. So Horowitz describes two elements that affects an individual and how their mental illness may be viewed. So incomprehensibility, which is the inability for the general population to understand the motivation behind the behavior, and cultural relativity, which is the normality of behavior, which is determined by the culture. So now we're going to talk about Maslow's hierarchy of needs. So I know you guys learned this in foundations. There are five different levels, and each level must be met before you can progress to the next level. So you have your physiological needs, which is your basic needs for living. Then you also have, so we're talking about water and food, right? Basic needs for living. Next level would be safety and security. Your next level is love and belonging. The next level is self esteem. And the final level is self actualization. So, self actualization is the highest level, and that's when one achieves their highest potential. So, psychologically healthy person, they are fully evolved and mature. According to Maslow, this self actualization state, a mentally healthy person is motivated to progress to self actualization or their highest potential. And that's according to Maslow. Hans Selye defined stress as the state manifested by a specific syndrome, which consists of all that are non-specifically induced and changes within the biological system. So this syndrome has come to known as the fight or flight syndrome. So I'm sure you guys have learned that in the past. So it describes how the body reacts to stress and general adaptation syndrome. So Saley's general adaptation syndrome has three different phases. The first phase is alarm reaction stage. The fight or flight syndrome is initiated in this stage. So you may start to have increased heart rate, increased respirations. And the second stage is called the stage of resistance. And the person attempts to adapt to the stressor during this stage. If the adaptation occurs, the third stage is prevented or delayed. The physiological symptoms may disappear. However, if it progresses, then you have your stage of exhaustion. And this adaptation energy is depleted, and the disease of adaptation may ensue. So your body is making a physiological um, response to the stressor, okay? And this is our fight or flight syndrome, also known as adaptation syndrome. So, the physical response to stress. So, we have our biological response associated with flight, fight or flight syndrome. So, the first one is an immediate response, and the next one is the sustained response. So, the sustained response to stress occurs after a prolonged period of stress has occurred and promotes susceptibility to many diseases and adaptation. And so the pituitary gland releases hormones that causes a range of um, effects on your body. So remember, the stress can kill you, right? Then we have our immediate response. So the immediate response is stimulated by the sympathetic nervous system. And some of the responses that this cause is dilation of pupils, dilation of the bronchioles, increased respiratory rate. Your heart or cardiac contractions may start to occur, an increase in cardiac output, heart rate increases, blood pressure increases, GI motility decreases, and production of sweat increases. So this is the immediate response to stressor. As if it's prolonged, then different systems and organs start to become affected. And that's where the term that stress will kill you comes from. So there are two psychological responses to stress. So one is anxiety, the other one is grief. So anxiety and grief can paralyze a person where they become non functional, or they can motivate a person to change the world. So here's a few examples. So a mother lost their child to a drunk driver, organizes an awareness group. So this is her attempt to change the world. So she's motivated to make a difference. A mother lost a child and she stops working, loses her house, neglects herself and family, stays in the bed unkept for weeks or months. So this is the opposite, right? So this is the anxiety and grief causing the person to become paralyzed and non functional. So let's define anxiety. Anxiety is a feeling of discomfort and apprehension related to fear of impending danger. The individual may be unaware of the source of anxiety, but is often accompanied by feelings of uncertainty and helplessness. Mild anxiety is adaptive and can provide motivation for survival. So, a mild level of anxiety is good. It actually keeps you focused and it keeps you alert. Paolo's 4 levels of anxiety. The first one is mild, so that's seldom a problem. Second level is moderate. Perceptual field begins to diminish. The third one is severe. Perceptual field diminishes greatly. And the fourth level of anxiety is panic. And this is the most intense state of anxiety. So I want to point out a few key factors in reference to these different levels of anxiety. So mild anxiety prepares a person for action, and the person is ready to achieve their optimal level. Moderate anxiety, muscles start to become tense, the person becomes restless, and the person becomes less alert. So during your exam, you may have scenarios where you have to identify what type of anxiety is being exhibited. So I want you to know exactly what each level looks like. So severe anxiety, the person has emotional symptoms which include confusion, dread, horror. They may experience headaches, palpitations, insomnia. So their life is kind of being disrupted, right? And for our panic level, misperceptions are common, and a loss of contact with reality is common. So human function and communication with others becomes ineffective. Prolonged panic anxiety can lead to physical and emotional exhaustion and can be life threatening illness. So you have to recognize that anxiety is caused by stress, and if in fact anxiety is not treated and it progresses to a level of panic, then that stress or that panic level anxiety will have a negative effect on your body and cause you to come to a point of complete exhaustion physically, and your systems and organs will start to break down and possibly cause life threatening illness. At the mild level, stress that causes mild anxiety, people will try to use different coping mechanisms to deal with this anxiety. So, some of the coping mechanisms include eating, drinking, sleeping, or even physical activity such as exercise. So, coping skills are coping behaviors that enhances one's adaptability. So sometimes you'll see someone have a nervous laughter, so they're laughing, but there's nothing funny that was said or done. So this is just an anxiety, a way of dealing with a mild level of anxiety. So going from a mild to a moderate level, the strength of the ego is tested, and the energy is focused on confronting the threat. So your textbook mentions the ego defense mechanisms that are employed to protect the individual. So I believe my textbook may have a different page number than yours, but I have table 1-1, and for my textbook it is page 7. So I need you to make sure you read through all of your defense mechanisms, have an understanding of all your defense mechanisms. And later on, we'll try to do a review and maybe zone in on some specific ones. However, I need you to read through them and make sure you have an understanding of them. So, some of the defense mechanisms include denial, isolation, projection. So, note you will see defense mechanisms in use when, I'm sorry, your defense mechanisms will be in use to help you remember. Oh gosh, I'm sorry. Make sure you remember when defense mechanisms will be in use. I apologize. I could not read my own notes. So, unresolved anxiety can lead to psychosis. Okay? So, it can cause physical damage to your body, but it also can cause mental damage to your body as well. So, psychosis, the person may experience hallucinations and delusions. They may develop psychiatric disorders such as schizophrenia, schizoaffective disorder, or delusional disorder. So, some of the common characteristics of a person that's experiencing psychosis include that they may exhibit minimal distress, but everyone else does see a maximum of distress. When you look at them, you can tell that they are out of sorts. However, they are quite in a state of content, like they feel like that what they're doing is normal. They are unaware of their behavior, that it is maladaptive. They exhibit flight from reality into a less stressful world, or into one in which they can attempt to adapt. So their brain is creating a psychological, almost a delusion or hallucination where they can actually deal with what's happening in that reality opposed to dealing with what is actually occurring in reality. So once again, unresolved panic anxiety can result in psychosis, disturbance in reality is impaired. The person may experience delusions, hallucinations, disorganized speech, and catatonic behaviors. So I want you to remember these symptoms. When we talk about schizophrenia, many of those symptoms will be very similar. Okay, so now let's define grief. So grief is subjective state of emotional, physical, and social responses to the loss of a valued entity. So the loss may be real or perceived. So I did mention that um, a little while ago when I talked about anxiety and grief together. So now we're just breaking them down separately. So I want you to know the 5 stages of grief according to Kubler-Ross. So first stage is denial. Denial is a stage of disbelief in which reality of the loss is not acknowledged. So a child's father may die and they may not believe that their father's dead. Anger is the second stage. Anger is a stage of envy and resentment. So the person is left with questioning, why me? Why did this happen to me? Why did my father have to pass away? The third stage of grief is bargaining, stage of making promises to reverse or postpone the loss. So the dying wife, um, if she lives, I'll promise to show love to her. So this is the husband, like almost bargaining with God. If you allow my wife who's dying to live, I'll do better by her. I'll love her the way you want me to love her, or the way she should be loved. Okay, this is considered bargaining. So this stage is making promises to reverse or postpone the loss. I need you to make sure you know the 5 stages, but special attention to bargaining. Depression, stages of despair and disengagement. So, in this stage, the person is mourning for what was lost. So, with this mourning, regression can occur. So, an example of this is someone experiences a stroke or a CVA with left sided paralysis. So, the patient then neglects that side, totally disengages that side. So, depression stage is the stage of desperation and disengagement. So, they're mourning their loss. And the final and fifth stage is the final stage of resignation. So the person is ready to die if terminally ill, or they have a less focus on their loss. So if we have the same patient that had the CVA or the stroke that had left-sided paralysis, now they are accepting that they are limited and they're accepting their loss. They're caring for that left side and they are no longer neglecting that left side. So grief is a loss of anything that is perceived a loss by that individual. So I want you to remember that. And so here we're talking about grief. So we have anticipatory grief. And anticipatory grief is the experiencing of grief process before the actual loss occurs. And then we have resolution. So the length of grief process is entirely individual and can last from weeks to years, and it's influenced by a number of factors. So the um, feeling of guilt may prolong the grieving process. So if a person had a love-hate relationship with an individual, this may prolong the grieving process because they may feel guilty. Anticipatory grief is often thought to shorten the process of grief, the grief response, when the loss actually does occur. So the length of the grieving response is often extended when someone does not have a chance to mourn before another loss occurs. So a number of recent loss may prolong the grieving process as well, or extend it. Resolution of grief response is thought to occur when an individual can look back at the relationship with the lost entity and accept both the pleasure and disappointment of their association. So let's talk about maladaptive grief response. So prolonged response. Prolonged response is characterized by an intensive preoccupation with the lost entity. Delayed or inhibited response. That is when an individual becomes stuck in a denial stage of grieving process. And then we have the distorted response. The distorted response in which the individual becomes stuck in the anger stage of the process. So these are maladaptive responses to grief responses rather. And that is it for chapter 1. Chapter 5, Relationship Development and Therapeutic Communication. So the nurse-patient relationship is the foundation on which psychiatric nursing is established. This relationship is very important. The therapeutic interpersonal relationship is the process by which the nurse provides care to the patient in need of a psychosocial intervention. Therapeutic use of self is the instrument for delivery of care to patients in need of psychosocial interventions. So, interpersonal communication techniques can be both verbal and nonverbal. And therapeutic use of self is an instrument for delivery of care. So, the therapeutic nurse patient relationship occurs only when the patient and the nurse can view each other as human beings. Therapeutic relationships should always be the goal of the nurse, and it is directed at learning, growth, and growth promotion. So your patient is able to receive better from you when this relationship is developed. This relationship is based on trust, and so therefore, when you're teaching, when you're caring for the patient, they'll be more receptive to your care. Goals are often achieved through the use of problem-solving model. So the nurse should work to identify what's troubling the patient, show that you are concerned about what concerns the patient. This will help develop your relationship as well as trust level with your patient. Encourage the patient to talk about or discuss what is concerning them. Discuss what changes are possible or which are not possible. Help the patient to explore their feelings about things that they cannot change and discuss any alternative strategies for creating change for this resident or his patient. With the problem solving method, or model rather, the nurse should weigh the benefits versus the consequences for the alternatives, assist the patient to select an alternative if that is an option, encourage the patient to implement the change, provide positive feedback for the patient's attempt to create change, and assist the patient to evaluate outcomes of the change. So let's review therapeutic use of self. So it is the ability to use one's personality consciously and in full awareness in an attempt to establish relatedness and the structure of nursing interventions. All right, so some essential conditions to development of a therapeutic relationship. So I mentioned trust a little bit ago, so there are several more, and I want you to know these. This is important for you to know, okay? Rapport. So developing rapport implies special feelings on the part of both patient and nurse based on acceptance, warmth, friendliness, common interest, a sense of trust, and non judgmental attitude. Then trust. So you must feel confident in the person's presence, reliability, integrity, veracity, and sincerity. The third is respect. So, to show respect is to believe in the dignity and worth of the individual, regardless of his or her unacceptable behavior. The attitude is non judgmental, and respect is unconditional in that it does not depend on the behavior of the patient to meet certain standards. Fourth is genuineness. Genuineness refers to the nurse's ability to be open, honest, and real in their interactions with the patient. Then the fifth one we have here is empathy. So, empathy is the ability to see beyond outward behavior and to understand the situation from the patient's point of view. With empathy, the nurse can actually perceive and understand the meaning of the relevance of the patient's thoughts and feelings. So, I want you to know all these essential components to developing a therapeutic relationship. I am going to say special attention to empathy, trust, and genuineness. Therapeutic nurse patient relationship. So we have different phases. So the first one we'll speak about is our pre interaction phase. So during this phase, information is obtained from the patient's chart, significant other, or other health members of the team. The nurse is then examining his or her own feelings, fears, or anxiety in reference to working with this patient. So the nurse has to decide if he or she is comfortable caring for this patient, and the willingness to work with the patient is very important in developing the patient nurse relationship. So it is important for you to know all of these phases. Okay? So the therapeutic nurse relationship, the next phase is orientation, which is the introductory phase. The orientation phase is when the nurse and patient become acquainted with each other. So it creates a environment of trust and rapport. Establish contract of intervention. Gather assessment data. Identify the strengths or limitations of the patient. So this all occurs during the orientation or introductory phase. During the introductory phase, the nurse also formulates a nursing diagnosis. The patient and nurse sets mutual goals. So once again, we are not dictating to the patient their care. We're getting them to buy into it. We're explaining their conditions, we're explaining the interventions, and we're getting them to buy into the goals so that they can acquire optimum health. Okay, so it's mutual agreeable goals. Develop a realistic plan of action. Explore feelings of both patient and nurse. So this is all during our orientation phase or our introductory period. The next phase is our working phase. So during our working phase, trust and rapport that we have developed, they're maintained. So promotes the patient's insight and perception of reality. Use problem solving model to work toward achievement of the established goals that you guys mutually agreed upon. You're going to overcome any resistant behaviors during this phase. So maybe the patient is has an aversion to needles, and so maybe that is something that we need to overcome during this phase as you do patient teaching. Continuously evaluate the progress toward the goal that was set by you and your patient. During the working phase, transference may occur. Transference occurs when the patient is unconsciously displaces the nurse's feelings formed towards a patient of, a person of his or her past. So let me read that again. Transference occurs when the patient unconsciously displaces or transfers to the nurse feelings formed toward a person from their past. So maybe this person is a teenager, and they're looking at you as a motherly figure. So they may displace or transfer their feelings that they have towards their mother to the nurse. Then we have common transference. Common transference refers to the nurse's behavioral and emotional response to the patient. Okay, so these responses may be related to unresolved feelings towards significant others, from the nurse past, or response to transference. So, believe it or not, transference and common transference commonly occurs. And you do want to remember that they occur in the working phase of the therapeutic nurse patient relationship. Transference, counter transference occurs in the working phase. That could possibly be a test question. All right, then our final stage is our termination phase. Therapeutic conclusion of a relationship occurs in the termination phase. Termination of the relationship may occur for a variety of reasons. The mutually agreed on goals may have been reached or met. The patient may be discharged from the hospital, or in the case of a student nurse, the rotation of their clinical experience may end. So there may be several different scenarios why this relationship may terminate. However, it is designed to terminate at some point in time, right? So there are boundaries in the nurse-patient relationship. So the types of boundaries include material, which are physically seen, such as fences, or the nurse's station, something that divides the nurse from the patient, right, physically. Then you have social, behavior in social settings. So these are culturally influenced as well. Then you have personal boundaries. So distance, or how close physically, is considered too close. So boundaries are borders and limits in a relationship. They determine the extent of acceptable limits. It is important for both the nurse and the patient to understand these boundaries. Professional boundaries limit and outline expectations of appropriate professional relationships with patients. Professional boundary concerns commonly include issues with self disclosure, gift giving, touch, friendship, or romantic association. So, some warning signs that indicate professional boundaries of the nurse patient relationship may be in jeopardy. So, that includes favoring one person or one patient over another, keeping secrets with a patient, changing um, the style of dress at work for a particular patient, swapping patient assignments to care for a particular patient, giving special attention or treatment to one patient over others, spending free time with the patient, frequently thinking about the patient when away from work, sharing personal information or work concerns with the patient, receiving of gifts, or continued contact and communication with the patient after discharge. Interpersonal communication is a transaction between the sender and the receiver. Both persons participate simultaneously. In transactional model, both participants perceive each other, listen to each other, and simultaneously engage in the process of creating meaning in a relationship. The impact of pre-existing conditions. So values, attitudes, and beliefs are learned ways of thinking. Culture and religion, cultural morals, norms, ideas, and customs provide the basis for our way of thinking as well. The impact of pre existing conditions continued. So we have our social status. So, social status, high status person, often conveyed with high powered position, with gestures of hands on hips, power dress, greater height, and more distance when communicating with individuals considered to be of lower social class. Gender, masculine and feminine gestures, influence messages conveyed in the um, communication with others. So gender influence um, varies from culture to culture, as well as times have been changing with the various gender types that we have currently. And there's a difference um, in what is considered masculine versus feminine. So, age or developmental level influence communicates, especially during adolescent years. So, an example of this is the influence of developmental level of communication is especially evident during adolescent years with the words or the different phrases they may use, such as dude, cool, awesome. And I'm sure there's other phrases that's probably more up to date. The environment in which the transaction takes place. So, territorial, the innate tendency to own space, density, the number of people within a given environmental space, distance, the means by which various cultures use space to communicate. Impact of pre existing conditions continued. So there are four types of or kinds of distance and interpersonal interaction. So we have intimate distance. I will not read the definitions, they're on your slides, but I will give you some ideas as far as the numbers. So, intimate distance is considered 0 to 18 inches away from each other. Then you have your personal distance, which is 18 to 40 inches away from each other. You have your social distance, which is considered 4 to 12 feet away from each other. Then you have public distance, which exceeds 12 feet away. So, as we begin this lecture, we talked about both verbal and nonverbal communication and how they are both significant. So, now we'll talk a little bit about verbal communication. The components of we'll talk about nonverbal communication, not verbal, nonverbal communication. So the components of nonverbal communication include physical appearance and dress, body movement and posture, touch, facial expression, eye behavior, vocal cues, and paralanguage. Therapeutic communication. You need to know your therapeutic communication techniques. There are several of those in your textbook. So in my notes, I have table 5-3. My page numbers may be slightly different than yours. I have page 112 to 119. So make sure you read through them and understand them. I will not read each therapeutic communication to you, as there are several. So the first one is the use of silence. Yes, so silence is a therapeutic communication technique. So if you're having a discussion with the patient and the patient pauses and initiates silence, you want to allow that silence to happen. Oftentimes, as healthcare professionals, we are uncomfortable with that dead space and that silence, and we want to fill it with a question or some type of conversation. However, allow the patient to have control of the discussion, allow the patient to reinitiate the conversation. Okay? So, silence is golden, and at this moment in our communication technique, use of silence is necessary until the patient resumes the conversation. Do not rush the patient, do not force a response. Let the patient gather their thoughts. The next one is accepting. And so I do want to mention the definitions for all of these techniques are on your slide. They're also in your textbook on table 5-3. However, there will be some that I will point out, and maybe a few I'll give special attention to, which just means I want you to really make sure you know that particular one. All right, so we have acceptance, then we have giving recognition, then we have offering of self. So offering of self is making oneself available. Okay, so making oneself available is just that, being present, right? Being present, being willing to be present. So I'm here if you need me, right? So you're offering of self. So you need to know offering of self. Special attention to offering of self. Giving broad openings and allowing the patient, I'm sorry, not the patient to, yes, the patient to select the topic of choice. Allow them to tell you what's bothering them, what brought them there, right? You want to give them an open-ended question. Offering general leads. So this encourages the patient to continue to talk about whatever topic was on their mind, right? So you don't want to lead the conversation, but you do want to offer general leads. So if they're explaining to you how, they can't really care for themselves, they're dependent now, and this is affecting their life and their quality of life, then you want to just offer leads. So tell me more about, how you're feeling, dependent on your daughter, for for care, or um, so you want to allow them to continue to express their feelings. Okay? Placing the event in time or sequence. Making observations. Encouraging descriptions of perception. Encourage comparison. Restating. So, restating is important. So, it lets the patient know that you're listening to them, right? And you are also making sure that you're understanding what the patient's saying. Reflecting. Focusing. Exploring. Seeking clarification or validation. Presenting reality. Voicing doubt. Verbalizing the implied. Attempting to translate words into feelings. Formulating plan of action. So if you know you have a patient that struggles with stress or struggles with anxiety, so you want to try to formulate a plan to um, deal with that when stress occurs, or deal with the anxiety level as it starts to rise, right? So formulate a plan. So now let's talk about non-therapeutic communication. So this in my text is on page 114 to 116. However, your text numbers may be slightly different. So non-therapeutic communication techniques are techniques that we do not want to use, we do not want to display. So giving reassurance. Giving reassurance may discourage the patient from further expressing their feelings, right? We always want to encourage them to express their feelings, so giving reassurance is not what we as healthcare providers would like to do. Rejecting, so refusing to consider the patient's idea or behavior. So this is basically saying that your idea is not important or it's not valid. So we want to hear them out. And maybe we may not be able to accommodate the request, but we don't want to totally dismiss it. We want to then evaluate the request, find out what was the objective of that request, and try to see if there's alternatives that we can help that patient meet the goals that they have set for themselves, or utilize an intervention that is very similar to what they were looking to do, if possible. Approving or disapproving. So we do not want to approve or disapprove. This implies that the nurse has the right to pass judgment on what is good and what is not or bad, right? So we do not want to approve or disapprove anything. We are not agreeing or disagreeing. We want to maintain a non judgmental, neutral ground. This gives the patient the impression that um, our opinion is right or wrong. So we don't want to agree or disagree, but you can be a listening ear for your patient, right? We never want to imply any type of judgment. Giving advice. So we do not give advice to our patients. Sometimes the patients may ask you, well, what would you do in this situation? If you had this diagnosis, what would you do? Would you get chemo and radiation? And you can politely state that you are not at liberty to answer that question, because this is a decision that they have to make on their own or with their loved ones in reference to their health. And everyone's situation may be slightly different. So, giving advice implies that the nurse knows what is best for the patient and that the patient is incapable of any self direction. So, we do not want to give advice at all. Okay, this is a non therapeutic communication. Probing. So you don't want to push for answers to issues that the patient does not wish to discuss, right? You do want to use therapeutic communication techniques where you leave open ended questions, allow them to express, maybe give them some general leads. However, if the patient hits a standstill with the conversation, with the discussion, and does not want to discuss any further details, then we are not probing. And we are only asking for information pertinent to the patient's health and their health status. Okay? Defending is to defend what the patient has criticized, implies that the patient has no right. To defend what the patient has criticized implies that the patient has no right to express ideas, opinions, and feelings. So we do not want to criticize the patient where the patient now becomes defensive, and they feel that their ideas or thoughts are not valid or not valued. Requesting an explanation. So asking why. You never want to ask why. Asking why places the individual on a defensive mode, right? It implies that the patient must defend his or her behavior or feelings. So you never want to ask your patient why. And you probably don't want to ask anybody why unless you absolutely have to. Indicating the existence of an external source of power. Encourages the patient to place blame on his or her thoughts and behaviors on others. So we do not want to indicate that there's another source of power that exists that is considered non therapeutic. Belittling feelings expressed. So cause the patient to feel insignificant or unimportant when you belittle their feelings that's expressed. Making stereotyped comments, cliches, and trite expressions. These are meaningless in a nurse patient relationship. So you want to avoid all of these items. Using denial builds discussion with the patient and avoids helping the patient identify and explore areas of difficulty. Interpreting results in the therapist telling the patient the meaning of his or her experience. Introducing an unrelated topic causes the nurse to take over the directions of the discussion. So, active listening. You want to know what active listening is. Active listening is to listen actively, be attentive to what the patient is saying, both verbally and non-verbally. Several nonverbal behaviors have been designed to, to facilitate attentive listening. So, active listening, we have an acronym to help us remember it, and it's called SOLER, SOLER. So, our S stands for sit squarely facing the patient. O stands for observe an open posture. So you don't want arms crossed, legs crossed, right? You want an open posture. Lean forward. Lean is our L towards the patient. So you don't want to be pushed back or move to the side away from the patient. You want to lean forward, lean in, and be inviting. E, establish eye contact. So you don't want to look up above them, below, around, all around the room. You want to look them directly in their eye. And sometimes there is a cultural thing depending upon your patient's culture. Um, but generally in America, we're able to look each other in the eye. It's culturally acceptable. And the R is relax. So you want to have an open, relaxed posture, leaning toward the patient, facing the patient, and providing eye contact in a relaxing manner. This is the SOLAR acronym for active listening, to be attentive to your patient. Motivational interviewing is evidence-based, patient-centered style of communication that promotes behavior change by guiding the patient to explore their own motivations for change and the disadvantages and advantages of their decisions. It incorporates active listening and therapeutic communication techniques, but focuses on what the patient wants to do. Process recordings are verbal. I'm sorry, are written reports of verbal interactions with the patient. Process recordings are written reports of verbal interactions with the patient. They are written by the nurse or student as a tool for improving communication techniques. Feedback is a method of communication that helps the patient consider a modification of behavior. Feedback gives information to the patient about how they are being perceived by others. It should be presented in a manner that discourages defensiveness on the part of the patient. So it is well timed, imparts information that rather than offering advice. It is specific rather than general. It is descriptive, not evaluative, and is directed toward behavior that the patient has the capacity to modify. So this feedback is non judgmental. And that is all I have for you for Chapter 5. Chapter 6, the nursing process in psychiatric nursing. So, the systematic framework for delivery of care is the nursing process. It is used for problem solving approach to goal directed, in this goal directed, with its objectives being the delivery of quality of client care. It is dynamic and not static. So, this process is reoccurring to achieve the optimal health for your patient. ANA has 6 steps in the nursing process. So you may want to just take notes with this one. So patient-centered care, safety, teamwork and collaboration, evidence-based practice, informatics, and quality improvement. So these are known as QSEN, QSEN, which stands for Quality Safety Education for Nurses. Okay, so these are the 6 steps in the nursing process to shape the future and improve the quality of healthcare from ANA. So our nursing process, which I know you guys are very familiar with this because you learned this in foundations, and I'm certain you're utilizing this in the clinical setting as well. But this is a scientific method, okay, scientific based method. So you are assessing or reassessing the client. You develop a nursing diagnosis. So keep in mind that this diagnosis is not a medical diagnosis, it is a nursing diagnosis. So at risk for falls, at risk for skin breakdown, ineffective breathing, right? It's not COPD. It's not a fractured hip, right? That's a medical diagnosis. So, outcome or goal, then you have your plan, then you have implementation, and then you have evaluation. So, the standard of practice for psychiatric nursing is written around 6 steps of the nursing process. All right, so we're going to go through the nursing process. So, assessment is gathering information from which to establish a client database. So, with this on your test, you may see a scenario, right? And then you have to determine if they're doing the assessment portion, the nursing, the diagnosis portion, the outcome portion. What part of the nursing process is being implemented? So, you want to make sure you have a clear understanding of what is done in each phase of the nursing process. Okay? So, this information that you gather is used to determine the best possible care for your client. Okay? Then you have your diagnosis or nursing diagnosis, which is clinical judgment about the individual, family, or community experience in response to actual or potential health problems or life processes. So this provides the selection of nursing interventions. So we identify the problem here, right? So our nursing diagnosis is our problem, and then we're figuring out the interventions or what do we need to do in order to address our problem or fix our problem, if in fact that is a possibility. So I do want to mention that NANDA, NANDA, has a international nursing diagnosis classification list. However, some facilities don't necessarily use NANDA, but I do want to mention it. You should be aware of that. That there's an official list of nursing diagnoses out there. All right, next we have planning. Evidence-based interventions for achieving outcome criteria selected to meet the goal. All right, so we haven't gotten to the goal just yet. However, you have your nursing diagnosis. Now you're going to make sure that your nursing diagnosis connects with these interventions that you're planning to do, right? So these are evidence-based practice interventions. So nothing super deep, right? Very simple. Um, so, for instance, your patient, you do a fall assessment, your patient's at risk for falls, then you want to put interventions in place to prevent falls. So maybe the patient will have a low bed. Maybe they'll have mats on either side of their bed, right? So they may need assistance to transfer or to ambulate. They may need a rolling walker. So there's evidence based. So you're not going to say the person who's at risk for fall, I'm going to feed them a soft diet because that does not connect. That intervention is not evidence based practice for a fall, right? It does not connect to a fall. So you want to make sure that the intervention, the diagnosis connects together to meet the outcome or goal. Okay? So there is nursing intervention classification, which is a comprehensive standardized language describing the treatment that nurses perform in a setting or in all specialties, and it is abbreviated NIC. So these are based on research and reflective of current clinical practice. Outcome identification. Expected outcomes of care are identified. They must be measurable and estimate a time for attainment. Nursing Outcome Classification, or NOC, is a comprehensive standardized classification of patient outcomes developed to evaluate the effects of nursing interventions. Okay, so this is also linked to NANDA. So the NIC and the NOC are linked to NANDA. So with your outcome, as I mentioned before, your diagnosis determines what we're going to do, our plan of interventions, and then those interventions should lead to the goal that we have identified, right? Or the outcome that we have identified. Then you are going to implement your plan, right? So, implementation. Interventions selected during the planning stage are executed. So, specific interventions include coordinating of care, prescriptive authority and treatment, milieu therapy or group therapy, right? These are just some examples of specific interventions. And lastly, we have evaluation. So it measures the progress toward the attainment of the expected outcome or goal. Okay, evaluation is the process to determine the healthcare consumer's progress toward the goal and the effectiveness of the RN's care and interventions. And the patient's progress to the goal is being evaluated, right? So they may have met their goal, right? So then you can set a new goal, or maybe they have not met their goal and you're going to reassess and determine, do we continue with this plan of care, or do we need to revise this plan of care and do maybe a different intervention or change the goal to something else? Or maybe they're making progress and we need to change the goal because they are making progress. So, general and specialty standards are written around the 6 steps of the nursing process. It is defined in most states as the Nurse Practice Act or as a legal responsibility of the nurse. And the nursing diagnosis promotes research in nursing. So, nursing case management. Case management is a health delivery process whose goals are to improve quality healthcare, decrease fragmentation, enhance the client's quality of life, and contain costs. So, case management, um, or the case manager negotiates with multiple providers to obtain a diverse services. The case management is also used to achieve the nursing goals, right? So, managed care is a concept designed to control the balance between cost and quality of care. Individuals receive care based on needs, which is determined by the coordinator of the providership. So, that would be the insurance company. The nurse that's doing the case management would then follow a critical medical pathway to determine what would be the appropriate care for that individual based on evidence based practice, um, and approve the care accordingly. And then look for the expected progress. So, Critical Pathways of Care, or CPC, is the tool of provision of care in a case management system. So, I have a note here to see table 6-2 is a sample of a CPC. So, it's basically guidelines to help you achieve the goal, the designated goal for your patient. Okay, so let's talk about concept mapping. Concept mapping is a diagrammatic Teaching and learning strategies. I don't know if you guys utilize this, um, but oftentimes in clinical settings, we utilize this for drug, not really drug cards, but we'll do like a medication concept map, and then we may do a diagnosis concept map on your patient. So where you look up your different categories for your medication and um, side effects, interactions, and all categories, classifications, as well as for diagnosis. You may have one for diagnosis when you look at the signs and symptoms, nursing care, different labs that may be monitored. What is the diagnosis? Risk factors for the diagnosis. So this is all evidence based. CPCs may be standardized because they are intended to be used for uncomplicated cases, right? So we're following like a ideal plan to treat that particular diagnosis. Applying the nursing process. So the role of the nurse in psychiatry is to assist the client in successful adaptation to stressors within the environment. Goals are directed toward change and thoughts, feelings, behaviors that are age appropriate, congruent with local and cultural norms. Sound familiar, right? Sound like mental health. So we want them to achieve mental health, right? The nurse is a valuable member of the interdisciplinary team. So our goal is to help them manage stressors and become mentally healthy. Concept mapping is based on the nurse, the nursing process, and it helps students develop a holistic view of their client. So I am a firm believer in holistic care. We cannot treat just the physical element, but we must treat the entire person. We must look at the person as a whole being and find out what needs they actually have and meet them where they are. Documentation of the nursing process. So the nursing process and nursing diagnosis are mandated by Nurse Practice Acts in some states, and documentation are legal records. So it is required by some agencies that accredit healthcare organizations such as JAGO. A lot of people have heard of JAGO, especially if you work at a hospital. So they have certain standards, and in order to receive accreditation, you have to have your nursing process in place, nursing diagnosis, and documentation of such. So we'll review some different types of documentation techniques. So we have problem oriented recording or POR, POR, has a list of problems as its basis, uses subjective, objective, assessment, planning, intervention, and evaluation format. So that is our SOAPy note. Okay. So subjective is information gathered from the patient, the family, the the source of the chart, right? No, I'm sorry. Information gathered from what the client, family, or other sources have reported. Okay, that is subjective data. That's our S. O is our objective data, which is information gathered through direct observation by the person performing the assessment. Okay, so they may include physiological measurements such as blood pressure or behavioral responses such as the effect of a medication. A assessment, the nurse interpretation of the subjective and objective data. So that's your nursing assessment. P plan, the actions or treatments to be carried out may be omitted in daily charting if the plan is clearly explained in the written nursing care plan and no changes are expected. I, intervention, those nursing actions that are actually carried out. E, evaluation of the problem following the nursing interventions. So some nursing interventions cannot be evaluated immediately, so this section may be optional. So, for instance, if you have a person who has a stage 4 wound, it may take some time to show evidence of healing or evidence of deterioration if, in fact, what we are doing is not promoting healing, right? So, some do eliminate evaluation. However, most um, plans of care, the plan is being evaluated and reassessed as needed. Okay. So focus charting. The focus cannot be a medical diagnosis. Focus charting uses the DAR method or data action response format. DAR differs from POUR, or focus charting differs from POUR, the previous SOAPy method that we talked about. And the main perspective has been changed from the problem to focus. And data, action, and response or DAR format replaces the SOAPy. The focus of the documentation can be any of the following: nursing diagnosis, client's current concern, significant change in your client, or a significant event. The focus cannot be a medical diagnosis, as you just mentioned. So, our D for data, information that supports the stated focus or describes pertinent observations about the client. A, action, immediate or future nursing actions that address the focus and evaluation of the present care plan along with any changes required. R, response, description of the client's response to any part of the medical or nursing care. Next, we have our API method, which is a problem-oriented system. Uses flow sheets as accompanied documentation. Uses assessment, problem, intervention, and evaluation. So it's API format. And it is a problem-oriented system. A is for assessment. We already know that's your nursing assessment. P is for problem. So do you have a problem list or a list of nursing diagnoses? I is our interventions, our nursing actions that we performed, and E, evaluation, outcomes of the implemented interventions are documented here. Most healthcare facilities have implemented or are in the process of implementing some type of electronic health records, EHRs. So EHRs have been shown to improve both the quality of client care and the efficiency of healthcare system. There are 8 core functions of the EHR, and they include health information and data, results management, order, entry, order management, decision support, electronic communication and connectivity, patient support, administrative processes, supporting and population health management. Okay, and that concludes chapter 6 and concludes class lectures for class 1.